it actually mimics the native extracellular matrix, which is very important. Because what this allows is that it allows for the natural cellular adhesion and proliferation that the wounds really are looking for. The really good thing, and the thing I like the most, I think, about this product is that there's no animal or human cells. So you're eliminating that risk of a reaction from allogenic or xenogenic products. I don't know about everybody else, but there's many times where we've used a lot of different products, and you bring the patient back in a week and they have an infection to that area secondary to some kind of reaction to that product. So as I mentioned, this product is made of both PGA and PLCL fibers, which naturally biodegrade to glycolic, lactic, and caproic acids. And they do this by hydrolysis. These polymers, like I said, are really known by the body to accelerate the wound healing by decreasing the chronic inflammatory phase. And to me, that's one of the more important parts of this product, because it decreases that chronic inflammatory phase by decreasing the pH, therefore decreasing the microbial growth. So you're really able to control that microenvironment and decreasing that bacterial environment within the wound bed to try to accelerate the wound healing. At the same time, what this product does is that it increases the regenerative cellular activity and promotes angiogenesis. So the wound matrix polymers have different degradation rates, with the PGA fibers degrading at a much faster rate than the PLCL fibers. And what this allows is it allows the wound bed to rapidly acidify and clear out space within the actual matrix construct, which then allows for natural healthy tissue to be replaced into there, and it allows for the native extracellular matrix to migrate into this area. So what's very important about this is that knowing the degradation rates of these fibers makes this product predictable, and you'll actually see that in my cases that I present to you later today. So in this study, this is an in vitro study, and what the study showed, it showed a higher number of human dermal fibroblast cells that attach to the wound matrix after just 24 to 48 hours in culture compared to other products. And what this showed is the potential of this Phoenix wound matrix to provide support for cellular adhesion and proliferation, therefore favoring tissue regeneration. So I'll be showing you 4 of my more complex cases from this year. I'd like to start, the area I work in, I have a lot of non-compliance. A lot of it unfortunately has to do with socioeconomic. So I'm always trying to look for different ways to try to help our patients heal and get back to a normal lifestyle. Especially, we all deal with wounds. We know how complex it is and how frustrating it could actually be. So we'll get into my first. So this is a 32-year-old female diabetic who was admitted about this time last year with a diabetic foot infection. Short history about this female, very sick. Earlier in that year, she actually had 2 heart attacks and survived. But she presented, we obtained an MRI, and there was complete abscess of the plantar surface of her foot. So we took her in for her surgery immediately upon admission. And what we did is we did a partial first ray resection. We took her back into the OR a couple days later for her second surgery. And at this time, this is when I first applied that wound matrix. As you'll see in this case, as well as my other 3 cases, is that first application allowed for the wound preparation. And then the second application is what actually consistently shows the regenerative healthy tissue that we're always looking for. So about a week later, we took this young lady back in for her second surgery. And as you can see from the wound edges, more granular tissue compared to that first image. Most of the yellow looking tissue in the middle was actually mainly the actual matrix that was applied initially. So we did remove all that. I ended up doing a second application on this day and packed a lot of the graft into the plantar depth. The plantar depth went all the way live. So there was a big depth in that area. But what you can see within that first 3 weeks is the amount of granulation tissue that formed. And her wound continued to heal thereafter. The patient did end up transferring to a wound care center that was closer to her, but I did hear news from the physician who was treating her that she did go on to heal. Initially, when I first saw this patient, especially after the first surgery that we did for her, I really thought this individual was going to end up with a BKA of some sort. But thankfully, we were able to save her leg and get her back to normal function. This is another one of my patients. So we did obtain an MRI for this patient. The MRI came back completely negative, but as we know, radiography, you can only take it to, trust in it to a certain degree. So based on clinical suspicion, I did take the patient in for what I thought was initially just going to be incision and drainage. Tissue was completely non-viable, necrotic. The bone was completely necrotic, so we ended up doing a partial first ray amputation. And he had a crevice dorsal to the second metatarsal that I did pack the wound matrix in into the area. The patient left the next day, AMA. Ended up showing back into the office about 2 weeks later, as you'll see in this picture, with his foot looking completely edematous, erythematous, serous drainage, purulent drainage, the whole 9 yards. So we sent him back into the hospital, took him back in for further amputation and resection and wound debridement. And at this time, I applied my second application of the wound matrix. I did in conjunction use the wound vac as well. And you could see the amount of granulation tissue that did form to that wound after that second application. So like I said, that predictability value is there with this new synthetic wound matrix. This is probably one of my most complex cases that I've ever done in my career. So this individual, she first presented to our actual wound care center on July of 2021. She was being treated by one of the other wound care specialists in the wound center. She had venous ulcers circumferentially around both legs. Excruciating pain. This past year in about June, July, is when that wound physician asked if I would take her in for an OR debridement. She had too much pain. They weren't able to do any type of debridement in the wound care center efficiently. So I took the patient in. We did the VersaJet in July, and that's when I did my first application of the wound graft. The wound matrix. And what we did is we literally applied it to all areas of both legs. This patient was very aggressive. I wanted to take her in much sooner for a second debridement and application, but she kept pushing it off, pushing it off, pushing it off. But as you'll see, the amount of new skin formation that started to form in the months to follow. We finally did take the patient back in October for our second debridement and application. And my latest picture, you see how significant and how much healing and native tissue that this wound matrix was able to help us develop. The biggest thing I think for this patient is that she's pain-free. That was the biggest thing. I wish I could have videotaped her significant others when he first saw the wound for the first time after like 3 or 4 months, and just saw the amount of difference that there was. We're still treating this patient, but she's almost at complete resolution within 4 months of treatment after dealing with this for about 1.5 years at this point. This is another one of my patients. She was initially admitted for right foot cellulitis. Keep in mind, A1C 14, as many of our, unfortunately, that we see on a day-to-day basis. And to this day, she still states, Dr. Tachi, I'm getting myself together, I'm doing great. Her A1C is still about 11. Once this patient was admitted, at first we were kind of monitoring the cellulitis for the first day. I saw her the next day, and at that point I saw that increase in duskiness that started to happen to that fifth digit. So we ordered ABIs, and as you can see, the fifth digit was completely flat. I was actually in the room. I went and saw the patient as she was getting her ABI study done, and made sure that we actually tested the fifth digit in particular, because they did get great toe pressure, which great toe pressure is not that bad, but once you looked at the fifth toe pressure, it's completely flatlined. I'm sure all of you as well discussed a lot of your cases with vascular surgery. They're very, very important in the way that we treat patients. So after discussion with my vascular specialist, we agreed that partial fifth ray amputation would be beneficial for this patient. So we took her in. I applied my first application of the wound matrix, and we anticipated the patient should heal. Tried to get her back to her family doctor, get her blood sugar under control. Patient kept walking all over her foot, still was completely uncontrolled. Ended up with a recurrent infection, as unfortunately many of our patients do. And she was admitted back about a month later with recurrent infection, as you can see, about a month later. So we unfortunately had to take the patient back in. We did further resection of the fifth ray, and we did a partial fourth ray application and a second application of the Phoenix wound matrix. And you could see, like I said, that second application and the predictability value and how much granular tissue started to form. Unfortunately for this patient, she took a few more months than we wanted to heal. And that again was secondary to her out of control blood sugar, constant in and out, DKA, foot infections, just about everything that you could think of for this patient. This slide I think is the most important slide. You can see the amount of wound progression that happened after the second application with each and every one of these patients. Again, this is probably my favorite case that I've used the wound matrix on, and the amount of healing that we saw thereafter. So I'll leave you with this. A publication just got accepted for 2023, and it's a study of 50 wounds of different etiologies, with 70% of them being chronic. The thing about this wound matrix is, wounds, when we're treating wounds, they become very basic. And by basic, I mean their pH value increases significantly. So we want to get it down back to an acute phase and treat it with the acute phase. And what this wound matrix shows and represents is that ability to get it back down into that acute phase in order to actually treat these wounds and get them to a healing product. As we heard from before, a lot of patients always ask us, put us on antibiotics, and we're always prone to. I always stress that I think a lot of our resistant organisms to drugs are because we just keep putting patients on antibiotics. So eventually we get these superorganisms. So if we have a synthetic polymer like this that's gonna decrease and bring us back to that acute phase, and as well work on decreasing the pH and therefore decreasing that microbial growth, well, that's gonna benefit our patients and try to keep us away from continuously using antibiotics. And again, from this study, with 2 or fewer applications, there was complete healing within less than